Foundations of Maternal, Newborn, and Women's Health Nursing by Murray McKinney, Holub, and Jones, 7th edition, Chapter 13, Pain Management During Childbirth. Each woman has unique expectations about birth, including expectations about pain and her ability to manage it. The woman who successfully copes with pain of labor is more likely to view her experience as a positive life event. A woman's experience with labor pain varies with several physical and psychological elements, and each woman responds differently. Non-pharmacologic and pharmacologic methods offer a selection of pain management techniques from which the laboring woman may choose. Unique nature of pain during birth. Pain is a universal experience, but it is difficult to define. It is an unpleasant sensation of distress resulting from stimulation of sensory nerves. Pain involves two components: a physiologic component that includes reception by sensory nerves and transmission to the central nervous system, CNS, a psychological component that involves recognizing the sensation, interpreting it as painful, and reacting to the interpretation. Pain is subjective and personal. No one can feel another's pain. Evidence of pain is a person's reaction to it. Childbirth pain, however, differs from other types of pain in the following important respects. It is part of a normal process. Childbirth pain is part of a normal process, whereas other types of pain relate to injury or illness. Pain may lead a woman to assume different positions in labor, favoring descent of the fetus through her pelvis. Preparation time exists. The pregnant woman has several months to prepare for labor, including acquiring skills to help manage pain. Realistic preparation and knowledge about the birth process help her develop skills to cope with labor pain. It is self-limiting. Labor pain has a foreseeable end. Although it may be intense, a woman can expect her labor to end in hours rather than days, weeks, or months. Other kinds of pain may also be brief, but the baby's birth brings a rapid decrease in pain. Labor pain is not constant, but rather intermittent. A woman may describe little discomfort with contractions during early labor. Even during late labor, a woman may be relatively comfortable between contractions. Labor ends with the birth of a baby. The emotional significance of the child's birth cannot be ignored when trying to understand a woman's response to pain. Care about her fetus often motivates a woman to tolerate more pain during labor than she otherwise might be willing to endure. Adverse effects of excessive pain. Although expected during labor, pain that exceeds a woman's tolerance can have harmful effects on her and the fetus. Physiologic effects. Excessive pain can heighten a woman's fear and anxiety, which stimulates sympathetic nervous system activity and results in increased secretion of catecholamines, epinephrine, and norepinephrine. Catecholamines stimulate alpha and beta receptors, causing effects on the blood vessels and uterine muscles. Stimulation of the alpha receptors causes uterine and generalized vasoconstriction and an increase in the uterine muscle tone. These effects reduce uterine blood flow as they raise the maternal blood pressure. Stimulation of the beta receptors relaxes the uterine muscle and causes vasodilation. However, uterine vessels are already dilated in pregnancy, so dilation of other maternal vessels allows the woman's blood to pool in them. The pooling of blood reduces the amount of blood available to perfuse the placenta. The combined effects of excessive catecholamine secretion are as follows: reduced blood flow to and from the placenta, restricting fetal oxygen supply and waste removal. Reduced effectiveness of uterine contractions, slowing labor progress. Labor increases a woman's metabolic rate and her demand for oxygen, and anxiety increase her already high metabolic rate. She breathes fast to obtain more oxygen, exhaling too much carbon dioxide in the process. Significant changes, more than those expected during labor, can occur in the woman's partial pressure of oxygen, PaO2, and partial pressure of carbon dioxide, PaCO2, levels, and in her arterial pH. If persistent, these maternal respiratory and metabolic changes alter placental exchange significantly. The fetus may have less oxygen available for uptake and have less ability to unload carbon dioxide to the mother. The net result is that the fetus shifts to anaerobic metabolism, with buildup of hydrogen ions, acidosis. This type of acidosis is metabolic and does not resolve as quickly after birth as respiratory acidosis, which results from shorter periods of hypoxia. Psychological effects. Women have a surprising tolerance for labor pain. However, poorly managed pain lessens the pleasure of this extraordinary life event for both partners. The mother may find it difficult to interact with her infant because she is depleted from a painful labor. Unpleasant memories of the birth may affect her response to sexual activity or another labor. Her support person may feel inadequate during birth. The woman's partner may feel helpless and frustrated when her pain is unrelieved. Variables in childbirth pain. A variety of physical and psychosocial factors contribute to a woman's pain response during labor. These factors provide possibilities for nursing interventions for pain relief. Physical factors. Childbirth pain is of two types, visceral and somatic. Visceral pain is a slow, deep, poorly localized pain that is often described as dull or aching. Visceral pain dominates during first-stage labor as the uterus contracts and the cervix dilates. Somatic pain is quick, sharp pain that can be precisely localized. Somatic pain is most prominent during late first-stage labor and during second-stage labor as the descending fetus puts direct pressure on maternal tissues. Sources of pain. 4 sources of labor pain exist in most labors. Other physical factors may modify labor pain, increasing or decreasing it. Tissue ischemia. The blood supply to the uterus decreases during contractions, leading to tissue hypoxia and anaerobic metabolism. Ischemic uterine pain has been linked to ischemic heart pain. Cervical dilation. Dilation and stretching of the cervix and lower uterus are a major source of pain. Pain stimuli from cervical dilation travel through the hypogastric plexus, entering the spinal cord at the T10, T11, T12, and L1 levels, figure 13.1. Pressure and pulling on pelvic structures. Some pain results from pressure and pulling on pelvic structures, such as the ligaments, fallopian tubes, ovaries, bladder, and peritoneum. The pain is a visceral pain. A woman may feel it as referred pain in her back and legs. Distension of the vagina and perineum. Marked distension of the vagina and perineum occurs with fetal descent, especially during the second stage. The woman may describe a sensation of burning, tearing, or splitting, somatic pain. Pain from vaginal and perineal distension and pressure and pulling on adjacent structures enter the spinal cord at the S2, S3, and S4 levels. See figure 13.1. Factors influencing perception or tolerance of pain. Although physiologic processes cause labor pain, a woman's tolerance of pain is affected by other physical influences. Labor intensity. The woman who has a short, intense labor may complain of severe pain because each contraction does so much work: effacement, dilation, and fetal descent. A rapid labor may limit her options for adequate pharmacologic pain relief as well. Cervical readiness. If pre-labor cervical changes, softening with some dilation and effacement, are incomplete, the cervix does not open as easily as it does when it is soft and dilation and effacement have begun. More contractions are needed to achieve dilation and effacement, resulting in a longer labor and greater fatigue in the laboring woman. Fetal position. Labor is likely to be longer and more uncomfortable when the fetus is in an unfavorable position. An occiput posterior position is a common variant seen in otherwise normal labors. In this position, each contraction pushes the fetal occiput against the woman's sacrum. She experiences intense back discomfort, back labor, that persists between contractions. A woman may not be able to deliver the fetus until it rotates to the occiput anterior position. The fetal head must therefore rotate a wider arc before the mechanisms of extension and expulsion occur, so labor is often longer. See Figure 12.12. Back pain may decrease dramatically when a fetus rotates into the more favorable position. The rate of labor progress usually increases as well. However, back pain may persist in any labor. Pelvic Anatomy. The size and shape of a woman's pelvis influence the course and length of her labor. Abnormalities may contribute to fetal malpresentation and malposition, resulting in a difficult and longer labor. Fatigue. Fatigue reduces a woman's ability to tolerate pain and use coping skills she has learned. She may be unable to focus on techniques that would otherwise help her tolerate labor. An extremely fatigued woman may have an exaggerated response to contractions, or she may be unable to respond to sensations of labor, such as the urge to push. Because oral intake is often limited, her energy reserves are also likely to be depleted in a long labor. Many women find that sleep is difficult during the last weeks of pregnancy. A woman's shortness of breath when lying down, frequent urination, and fetal activity interrupt sleep, so she often begins labor with a sleep deficit. If labor begins late in the evening, she may have been awake more than 24 hours by the time she gives birth. Even if a woman begins labor well rested, slow progress may exhaust her. Caregiver interventions. Although they may be appropriate for the well-being of a woman and fetus, common interventions often add discomfort to the natural pain of labor. IV lines cause pain when inserted and remain noticeable to many women during labor. Fetal monitoring equipment is uncomfortable to some women, but others want to hear the sounds. Both may hamper a woman's mobility, which she might use to assume a more comfortable position. A woman may expect routine electronic fetal monitoring and subordinates her own comfort for reassurance of her baby's well-being with technology. A woman whose labor is induced or augmented often reports more pain and increased difficulty coping. Contractions reach peak intensity quickly. Labor is more interventional with induction or augmentation. See Chapter 15. Vaginal examinations, amniotomy, and insertion of internal fetal monitoring devices also increases a woman's discomfort briefly because of vaginal and cervical stretching. Vaginal manipulation often stimulates a contraction because of a reflex known as Ferguson's reflex. Psychosocial factors. Several psychosocial variables influence a woman's experience of pain. Culture. Woman's sociocultural roots influence how she perceives, interprets, and responds to pain during childbirth. Some cultures encourage loud and vigorous expression of pain, whereas others value self-control. However, women are individuals within their culture groups. The experience of pain is personal, and caregivers should not make assumptions about how a woman will behave during labor. Women should be encouraged to express themselves in any way they find comforting, and the diversity of their expressions should be respected. Loud and vigorous expression may be a woman's personal pain coping mechanism, whereas a quiet woman may need medication relief but feels the need to remain stoic. Accepting a woman's individual response to labor and pain promotes a therapeutic relationship. The nurse should avoid praising behaviors, such as stoicism, and belittling others, such as noisy expression. The unique nature of childbirth pain and women's diverse responses to it make nursing management complex. The nurse can miss important cues if the woman is either stoic or outspoken about her pain. With either extreme, the nurse may not readily identify critical information, such as impending birth or symptoms of a complication. Anxiety and fear. Mild or moderate anxiety can enhance attention and learning. However, high anxiety and fear magnify sensitivity to pain and impair a woman's ability to tolerate pain. Anxiety and fear consume energy the woman needs to cope with the birth process, including its painful aspects. Anxiety and fear increase muscle tension, diverting oxygenated blood to the brain and skeletal muscles. Tension in pelvic muscles counters the explosive forces of uterine contractions and the laboring woman's pushing. Prolonged tension results in general fatigue, increased pain perception, or threshold. lowest stimulus level perceived as painful, and reduced ability to use skills to cope with pain. If a previous pregnancy had a poor outcome, such as a stillborn infant or one with abnormalities, a woman is probably more anxious during labor and for a time after birth. She is likely to examine and re-examine her infant to assure herself that the baby is normal. Previous experiences with pain. Early in life, a child learns that pain means bodily injury. Consequently, fear and withdrawal are natural reactions to pain during labor. Learning about the normal sensations of labor, including pain, helps a woman suppress her natural reactions of fear and withdrawal, allowing her body to do the work of birth. A woman who has given birth previously has a different perspective. If she has had a vaginal delivery, she is probably aware of normal labor sensations and is less likely to associate them with injury or abnormality. Also, time has a way of blunting the memory of painful experiences. A woman who had a previous long and difficult labor may be anxious about the outcome of the present one. She may be surprised that her second labor moves more quickly than her first. The woman having a second or higher vaginal birth may find late first stage and second stage labor to be more painful because the fetus descends faster. All women are different and yet similar. A woman who plans a vaginal birth after cesarean VBAC but has never experienced labor may be particularly anxious. Experience of cesarean birth is known to her, even if she does not want to repeat it, whereas labor is unknown. A repeat cesarean birth may seem to be the quicker and less painful option at times, yet she strongly prefers a normal vaginal birth if possible. She may have difficulty yielding to the normal forces of birth. Previous experiences may positively affect a woman's ability to deal with pain. She may have learned ways to cope with pain during other episodes of pain or during other births and may use these skills adaptively during labor. Preparation for childbirth. Preparation for childbirth does not ensure a pain-free labor. A woman should be prepared for pain realistically, including reasonable expectations about analgesia and anesthesia, loss of sensation. She may feel that unexpected events during labor may invalidate her childbirth preparation. Preparation reduces anxiety and fear of the unknown. It allows a woman to rehearse for labor and learn a variety of skills to cope with pain as labor progresses. She and her partner learn about expected behavioral changes during labor, and their knowledge decreases their anxiety when those changes occur. Support system. An anxious partner is less able to provide the support and reassurance the woman needs during labor. In addition, anxiety in others can be contagious, increasing the woman's anxiety. She may assume that if others are worried, something is wrong. The birth experiences of a woman's family and friends cannot be ignored. Those individuals can be an important source of support if they express realistic information about labor pain and its control. If they describe labor as intolerable, however, she may have needless distress. Hearing that labor is painless is equally detrimental. No two labors are alike, even in the same woman. Standards for pain management. The Joint Commission has recognized that pain management is an essential part of the care of all people in healthcare settings and that the patient should be involved in the assessment and management of pain through pharmacologic and non-pharmacologic strategies. Non-pharmacologic pain management. The nurse who cares for women in labor and birth can offer many non-pharmacologic and pharmacologic pain management methods. Education about non-pharmacologic pain management is the foundation of prepared childbirth classes, although today's class contains significant content on pharmacologic pain management, particularly epidural analgesia. Women use these methods to complement pharmacologic methods, although some use them as their only pain management techniques. To be most helpful to women and their labor partners, the intrapartum nurse should know methods that are taught in local childbirth classes. Teaching techniques during labor that conflict with what a woman has learned and practiced may confuse her. Other techniques can be reserved for use if a woman finds learned techniques ineffective. Advantages. Non-pharmacologic methods have several advantages over pharmacologic methods if pain control is adequate. They do not slow labor and have no side effects or risk for allergy. Chooses analgesia needs alternative pain management until she receives it, usually after labor is established. Also, some pharmacologic methods may not eliminate labor pain, and a woman needs these techniques to control the pain that remains, even if it is greatly reduced. Non-pharmacologic methods may be the only realistic option for a woman who enters a hospital in advanced rapid labor. Drugs might not have enough time to take effect. There may not be time needed to administer an effective epidural block before birth. The time of peak drug action in terms of newborn respiratory effort should be considered if an analgesic systemic agent to relieve pain drug is given. Limitations. Non-pharmacologic methods also have limitations, especially as the sole method of pain control. Women do not always achieve their desired levels of pain control using these methods alone. Because of the many variables in labor, even a well-prepared and highly motivated woman may have difficult labor and need analgesia or anesthesia. Gait control theory. A discussion of non-pharmacologic pain management techniques would not be complete without discussion of gait control theory. Per this theory, transmission of nerve impulses is controlled by a neural mechanism in the dorsal horn of the spinal cord that acts like a gate to control impulse transmitted to the brain. Transmission is affected by stimulation of large or small diameter sensory nerve fibers and descending impulses from the brain. This mechanism opens or closes the gate to pain sensation by allowing or preventing some impulses from reaching the brain, where they are recognized as pain. Pain is transmitted through small diameter sensory nerve fibers. Stimulation of large diameter fibers in the skin blocks conduction of pain through small diameter fibers, thereby closing the gate and decreasing the amount of pain felt. Examples of this stimulation include tactile stimulation, such as massage, thermal stimulation, or hydrotherapy. Impulses from the brain have a similar ability to impede transmission through the dorsal horn using visual and auditory stimulation techniques. Examples of visual or auditory stimulation include use of a focal point or breathing techniques. Memory and cognitive processes affect the perception of stimuli as painful. Education and support during labor are used to increase the woman's relaxation, confidence, and feeling of control. Although these methods may not completely prevent pain, they may decrease the severity of perceived pain. Preparation for pain management. The ideal time to prepare for non-pharmacologic pain control is before labor. During the last few weeks of pregnancy, the woman learns about labor, including its painful aspects, in childbirth classes. She can prepare to confront the pain, learning a variety of skills to use during labor. Her support person learns specific methods to encourage and support her. After admission, the nurse can review and reinforce what the partners learned in class. The nurse can teach the unprepared woman and her support person non-pharmacologic techniques. The latent phase of labor is the best time for intrapartum teaching because the woman is usually anxious enough to be attentive and interested and yet comfortable enough to understand. The nurse should usually teach one contraction at a time during late labor because the woman's focus is very narrow. No one method or combination of methods helps every woman. Most methods may become less effective habituation after prolonged use, and changing techniques counters this problem. Knowing a variety of methods gives the nurse a selection. Can be applied during labor include relaxation, cutaneous stimulation, hydrotherapy, mental stimulation, and breathing techniques. Relaxation. Promoting relaxation is a basis for all other methods, both non-pharmacologic and pharmacologic, because it achieves the following. Promotes uterine blood flow, improving fetal oxygenation. Promotes efficient uterine contractions. Reduces tension that increases pain perception and decreases pain tolerance, maximum pain one is willing to endure. Reduces tension that can inhibit fetal descent. Environmental comfort. Comfortable surroundings support relaxation. The nurse can reduce irritants, such as bright lights and uncomfortable temperature, and can change soiled underpads. Music masks outside noise and provides a background for use of imagery and breathing techniques. This distraction shifts the woman's attention from pain perception. Television has a similar effect for some women. General comfort. The woman's personal comfort, helps her focus on using pain management techniques during labor, figure 13.2. This includes actions to increase comfort and reduces the effect of irritants. Reducing anxiety and fear. The nurse may reduce a woman's anxiety and increase her self-control by providing accurate information and focusing on the normality of her labor. Hospitals are typically associated with illness or injury, situations that provoke anxiety. Yet in North America, hospitals are the most common site for the normal event of birth. Simple nursing actions keep the focus on the normality of childbirth, regardless of the setting. Empowerment of the woman and her partner by giving them choices, whenever possible, helps them see themselves as competent people who can accomplish the task of giving birth. Specific relaxation techniques. Relaxation techniques work best if they are practiced before labor. During practice sessions at home, couples may practice progressive relaxation, in which the woman contracts and then releases specific muscle groups until all muscles are relaxed. Neuromuscular Disassociation helps the woman learn to relax all muscles except those that are working, e.g. the uterus or the abdominal muscles when pushing. The woman can learn touch relaxation in response to her partner's touch, and relaxation against pain as the partner deliberately causes mild pain and the woman learns to relax despite the pain. Even if the woman did not practice these relaxation techniques at home, the nurse can teach her how to consciously relax as labor progresses. The partner can learn to watch for signs of tension, touch that area, and direct the woman to relax. Cutaneous stimulation. Cutaneous stimulation has several variations that are often combined with each other or with other techniques. Self-massage. The woman may rub her abdomen, legs, or back during labor. Effleurage, to counteract discomfort. Some women find abdominal touch irritating, especially near the umbilicus. Women in labor may find firm stroking more helpful than light stroking. Some women benefit from firm palm or sole stimulation during labor. They may like someone to rub their palms vigorously, independently, to rub their hands or feet together, or to bang their palms on or grip a cool surface. They may hold another person's hand tightly during a contraction. The nurse should determine whether these actions indicate excess pain or if they are a woman's way of countering pain and therefore useful. Massage by others. Massage increases circulation and reduces muscle tension. The support person or nurse can rub the woman's back, shoulders, legs, or any area where she finds massage helpful. Body powder on the skin reduces friction during massage. Counterpressure. Sacral pressure may help when the woman has back pain, usually most intense when her fetus is in an occiput posterior position. Sacral pressure may be applied using the palm of the hand, the fist or fists, or a firm object such as 2 tennis balls in a sock. 13.3. A variation of sacral pressure is a double hip squeeze in which the palms are placed on the woman's hips and pressed down and inward toward the symphysis. When pressure is used, the woman should guide the support person as to the exact location and amount of pressure. An upright maternal position enhances counterpressure with the fists to the lower back. Touch. Non-clinical touch by the nurse is a powerful tool if the woman does not object to it. Holding her hand, stroking her hair, or similar actions convey caring, comfort, affirmation, and reassurance at this vulnerable time. Thermal stimulation. Many women appreciate warmth applied to the back, abdomen, or perineum during labor. Warmth increases local blood flow, relaxes muscles, and raises the pain threshold. Massage is often more comfortable to a tense woman after her skin is warmed. A warm shower, tub bath, or whirlpool bath is relaxing and provides thermal stimulation. A sock filled with dry rice and microwaved provides gentle warmth and can be used to apply warm pressure to the sacral area. Cool, damp washcloths provide comforting coolness if the woman feels hot. She may put them on her head, throat, abdomen, or any place she wants. She also may want to put them in her mouth to relieve dryness. Ice chips cool the mouth and provide hydration. Acupressure. Acupressure is a directed form of massage in which the support person applies pressure to specific pressure points using hands, rollers, balls, or other equipment. Related to its invasive counterpart, acupuncture, in which tiny needles are inserted into similar points. Acupuncture and acupressure have data to support effectiveness to relieve nausea and vomiting, including morning sickness of pregnancy. Few controlled studies exist on acupressure's usefulness during birth. For updated objective information on acupressure and other complementary and alternative medicine techniques, visit the website for National Center for Complementary and Alternative Medicine, which is part of the National Institutes of Health. www.blah blah blah blah. Hydrotherapy. Therapy can supplement any relaxation technique. The buoyancy afforded by immersion supports the body, equalizes pressure on the body, and aids muscle relaxation. In addition, fluid shifts from the extravascular space to the intravascular space, reducing edema as the excess fluid is excreted by the kidneys. Women who used water therapy effectively during the first stage had decreased use of anesthesia, analgesia, decrease in the duration of labor, and improved satisfaction. A shower, tub bath, or whirlpool bath is relaxing and provides thermal stimulation. Several studies have shown benefits of water therapy during labor, including immersion in a tub or a whirlpool, jet, hydrotherapy, or jacuzzi. The major concern about immersion therapy has been newborn and postpartum maternal infections caused by microorganisms in the water. Infections can be caused by the woman's own ascending vaginal bacteria or by pre-existing organisms in an improperly cleaned tub. However, several studies failed to find a significant association between newborn or postpartum maternal infections and use of immersion hydrotherapy with proper cleaning. More research is needed to clarify both the benefits and the concerns about hydrotherapy. Box 13.1. Facility policies should be written to outline specific guidelines based on most recent evidence for use of hydrotherapy. Mental stimulation techniques occupy the woman's mind and compete with painful stimuli. They also aid relaxation by providing a tranquil, imaginary atmosphere. Imagery. If the woman has not practiced a specific imagery technique, the nurse can help her create a relaxing mental scene. Most women find images of warmth, softness, security, and total relaxation most comforting. Imagery can help the woman dissociate herself from the painful aspects of labor. For example, the nurse can help her visualize the work of labor, the cervix opening with each contraction or the fetus moving down toward the outlet each time she pushes. This technique is like visualizing success or movement toward a goal with each contraction. The nurse can help the woman visualize being in a pleasant and relaxing place. Focal point. When using non-pharmacologic techniques, a woman may prefer to close her eyes or may want to concentrate on an external focal point. Childbirth classes may emphasize that keeping the eyes open on a focal point helps her concentrate on something outside her body and thus away from the pain of contractions. She may bring a picture of a relaxing scene or an object to use a focal point and to aid in the use of imagery. She can use any point in her room as a focal point. Breathing techniques. Breathing techniques give a woman a different focus during contractions, interfering with pain sensory transmission. They begin with simple patterns and progress to more complex ones as greater distraction is needed. No universal right time exists to change patterns during labor. However, complex patterns are fatiguing if used for a long time. For best results, the woman and her partner should practice techniques frequently. If patterns are too complicated or if the woman has not practiced, they may not be helpful during labor. Breathing techniques should be used only when needed, usually when the woman can no longer walk or talk during a contraction. The woman should not change from a simpler technique to the next, more complex technique until necessary, so that use of the most complex techniques is limited to the shortest time possible. First stage breathing. Breathing in the first stage of labor consists of a cleansing breath and progressively more complex techniques of paced breathing if needed. Taking a cleansing breath. Each contraction begins and ends with a deep inspiration and expiration known as the cleansing breath. Like a sigh, a cleansing breath helps the woman release tension. It provides oxygen to help reduce myometrial hypoxia, one cause of pain in labor. The cleansing breath also helps the woman clear her mind to focus on relaxing and signals her labor partner that the contraction is beginning or ending. The woman may inhale through the nose and exhale through the mouth, or take her cleansing breath in any way comfortable for her. When electronic monitors are used, a partner may help ease the discomfort of rapid contractions by watching for the rise in the lower part of the strip that signals the beginning of the contraction and telling the woman to take a cleansing breath. Slow-paced breathing. The first breathing is slow-paced breathing, a slow, deep breathing that increases relaxation, figure 13.5. The woman should concentrate on relaxing her body rather than on regulating the rate of her breathing. Relaxation naturally triggers slower breathing, like that during sleep. Slow-paced breathing is usually about half of the woman's normal respiratory rate. In 2, 3, 4, out 2, 3, 4. The woman can use nose, mouth, or a combination depending on which is most comfortable. Slow-paced breathing should be used as long as possible during labor because it promotes relaxation and oxygenation. Labor nurses often teach the technique to women who enter labor unprepared. Easy to learn between contractions, and when with the support of the nurse, helps even a frightened woman become calm and able to work with her contractions. As with all techniques, variety prevents habituation. Adding other pain relief approaches, such as effleurage, may help prolong the effectiveness of slow-paced breathing. Using another type of breathing for a short time may allow the woman to return to slower breathing again later. Modified paced breathing. When slow-paced breathing is no longer effective, the woman begins modified paced breathing, figure 13.6. Modified paced breathing is slightly faster than normal, but no more than twice the normal rate. In 2, out 2. Breathing at a faster rate matches the natural tendency to use more rapid breathing during stress or physical work such as labor. Although modified paced breathing is shallower than slow-paced breathing, the faster rate allows oxygen intake to remain about the same. As with slow-paced breathing, the focus is on release of tension rather than on the actual number of breaths taken. Women sometimes learn to combine slow and modified paced breathing during a contraction, figure 13.7. They begin slowly and use shallow, faster breathing over the peak of the contraction. During labor, women often do this naturally. The most important concern is ensuring that the breathing does not interfere with relaxation but enhances it. Pattern-paced breathing. Pattern-paced breathing, sometimes called pant-blow breathing, involves focusing on the pattern of breathing, figure 13.8. It is like modified paced breathing. After a certain number of breaths, however, exhales with a slight emphasis or blow, and then begins the modified paced breathing again. This addition causes her to focus more on her breathing and reduces habituation. The mouth should remain relaxed. The woman should not try to make specific sounds that would tighten her vocal cords. Relaxation of her entire body is the goal. The number of breaths before the blow is constant, usually between 2 and 6, or may change in a pattern. Variations include a set pattern such as 3-1, 5-1, 3-1, or a decreasing stair-step pattern such as 6-1, 5-1, 4-1, 3-1. Some couples use a random pattern determined by the coach, who uses hand signals to show the number of breaths the woman should take before each blow. The coach holds up fingers to show the total breaths to be taken, or a single finger for each breath. Use of the random pattern, however, may be ineffective without sufficient practice to enable the coach and the woman to work together well. Breathing to prevent pushing. If a woman pushes strenuously before the cervix is completely dilated, she risks injury to her cervix and the fetal head. Blowing prevents closure of the glottis, and breath holding helps to overcome the urge to push strenuously. The woman blows repeatedly using short puffs when the urge to push is strong. The support person may learn to blow along with her to help the woman concentrate. Some women vary the blowing by using one short breath and one blow. Overcoming common problems. Hyperventilation and mouth dryness are common when breathing techniques are used. Hyperventilation results from rapid deep breathing that causes excessive loss of carbon dioxide for respiratory alkalosis. The woman may feel dizzy or lightheaded and may have impaired thinking. Vasoconstriction leads to tingling and numbness in the fingers and lips. If hyperventilation continues, tetany occurring from decreased levels of calcium in tissues and blood may result in stiffness of the face and lips and carpopedal spasm. Women are taught to blow into a paper bag or their own cupped hands if they begin to feel dizzy. This kind of blowing increases the carbon dioxide levels by making the woman rebreathe her exhaled air. The woman should slow her rate of breathing to reduce the loss of carbon dioxide. The woman's mouth becomes dry with prolonged mouth breathing. To avoid dryness, she can place her tongue gently against the roof of her mouth to moisturize entering air. The support person can offer ice, mouthwash, sugarless suckers, or liquids as allowed. Second stage breathing. Care in the second stage of labor encourages a physiologic completion of labor, assisting the mother to respond to her urge to push rather than directing her to push as soon as her cervix is completely dilated, even if she does not feel the urge. Lengthy pushing in second stage has been shown to result in greater maternal fatigue, more operative births, and non-reassuring fetal heart rate, and does not significantly shorten the second stage. Research has shown that strenuous directed pushing increases risk for structural and neurogenic injury to a woman's pelvic floor. Closed glottis pushing causes recurrent increases in intrathoracic pressure with a resulting fall in cardiac output and maternal blood pressure. The woman's lower blood pressure then causes less blood to be delivered to the placenta, resulting in fetal hypoxia that is reflected in non-reassuring fetal heart rate patterns. Promoting a physiologic second stage uses non-directed pushing. The woman makes her decision with the nurse about when it is time to start pushing. She may grunt, groan, sigh, or moan as she pushes, and the nurse should validate that these sounds are normal. Pushing 3 to 4 times for 6 to 8 seconds is likely to be effective in aiding descent and safe for the baby. Adjust the pushing process depending on fetal status. See Chapter 15 for further discussion of second stage nursing care. With newer techniques of epidural analgesia, women who choose this method of labor pain control often feel the urge to push, although not as strongly as the urge felt by women who have not had this type of medication. Using their natural urge to push, even if reduced, helps them push with contractions most effectively. Delaying pushing for up to 1 to 2 hours after complete dilation has shown benefits similar to those in women who do not have epidural analgesia. Pharmacologic pain management. Most women choose pharmacologic pain relief at some point in their labor, even if they also use non-pharmacologic methods. Pharmacologic methods for pain management include systemic drugs, regional pain management techniques, block of pain in localized area with consciousness, and general anesthesia. Decisions for any method should be made on a risk versus benefit process. Considerations for medicating a pregnant woman. Medicating a woman when she is pregnant is not as simple as before pregnancy for the following reasons. Any drug taken by the woman is likely to affect her fetus. Drugs may have effects in pregnancy that they do not have in the non-pregnant person. Drugs can affect the course and length of labor. Pregnancy complications may limit the choice of pharmacologic pain management methods. Women who require other therapeutic drugs use herbal or botanical preparations, or practice substance abuse may have fewer safe choices for labor pain relief. Effects on the fetus. Effects on the fetus of drugs given to the mother may be direct, resulting from passage of the drug or its metabolites across the placenta to the fetus. An example of a direct effect on the fetus is decreased FHR variability after administration of an analgesic to the woman. Effects on the fetus may be indirect or secondary to drug effects in the mother. For example, if the drug causes maternal hypotension, blood flow to the placenta is reduced. Fetal hypoxia and acidosis may result. Maternal Physiologic alterations. Normal pregnancy changes in 4 body systems have the greatest implications for pharmacologic pain management methods. Cardiovascular changes. Compression of the aorta and inferior vena cava by the uterus can occur when a woman lies in the supine position, aortocaval compression. If the woman must be in the supine position temporarily, the uterus should be displaced to one side with the hands or with a small wedge or towel roll under one hip. Operating room tables are often tilted slightly to one side for a cesarean birth to provide the uterine displacement. Respiratory changes. A pregnant woman's full uterus reduces her respiratory capacity. To compensate, she breathes more rapidly and deeply. Thus, she is more vulnerable to reduced arterial oxygenation during induction of general anesthesia, systemic loss of sensitization and consciousness, and is more sensitive to inhalational anesthetic agents. The normal edema of pregnancy is also present in her upper airways and may present difficulty if she must be intubated for general anesthesia. Gastrointestinal changes. A pregnant woman's stomach is displaced upward by her large uterus and has a higher internal pressure. Progesterone slows peristalsis and reduces the tone of the sphincter at the junction of the stomach and esophagus. These changes make a pregnant woman vulnerable to regurgitation and aspiration, inhalation, of gastric contents during general anesthesia. Nervous system changes. During pregnancy and labor, circulating levels of endorphins and enkephalins, natural substances with analgesic properties, are high. These substances modify pain perception and reduce requirements for analgesia and anesthesia. The epidural and subarachnoid spaces between the arachnoid mater and pia mater are smaller during pregnancy, enhancing the spread of anesthetic agents used for epidural blocks or subarachnoid blocks. The spinal fluid pressure is higher during a contraction and when the woman is pushing. Nerve fibers are more sensitive to local anesthetic agents. High intra-abdominal pressure causes engorgement of the epidural veins, increasing the risk for intravascular injection of anesthetic agents. The net result of these changes is that a reduced volume of local anesthetic is needed to achieve satisfactory epidural blocks or SAB. Effects on the course of labor. Ideally, analgesics are given when labor is well established to avoid slowing progress. However, caregivers should consider the adverse effects of excessive pain on labor progress, regardless of the cervical dilation. Regional analgesia, primarily the epidural block, can slow progress during the second stage by reducing a woman's spontaneous urge to push. Effects of complications. Complications during pregnancy may limit the choices of analgesia or anesthesia. For example, large volumes of IV fluids are infused to prevent hypotension with regional analgesia and anesthesia. If a pregnant woman has heart disease, this fluid load could be detrimental. Yet without it, she is vulnerable to hypotension. Interactions with other substances. Ingest drugs, therapeutic, over-the-counter, or illicit, herbal or botanical preparations, or other substances may have fewer options because of interactions between these substances and analgesics or anesthetics. For example, recent alcohol use increases the depressant effects of opioid analgesics, making both the mother and the newborn susceptible to respiratory depression. Regional pain management techniques. Regional pain control methods may be used for intrapartum analgesia, surgical anesthesia, or both. These methods provide pain relief without loss of consciousness. Depending on the specific technique, it may be used for only labor, for only birth, or for both labor and birth. Epidural block provides pain control during much of labor and the birth itself. Intrathecal anesthetic agents and opioids are used for pain control during labor. Additional measures are needed during late labor and for the birth. Another regional block, the SAB, is used only at birth. A combined spinal epidural (CSE) analgesia allows subarachnoid injection of opioids via a spinal needle, followed by ongoing pain relief from anesthetics injected through the epidural catheter. Regional anesthetics with a small amount of anesthesia are used only for birth and include the local and pudendal blocks. A major advantage of regional pain management methods is that the woman can participate in birth and yet have good pain control. The woman usually feels some pressure and discomfort, although these sensations are greatly reduced. Protective airway reflexes remain. Disadvantages depend on the specific technique. The effects on the fetus depend primarily on how the woman responds rather than on direct drug effects. Epidural block. The lumbar epidural block is a popular regional block that provides analgesia and anesthesia for labor and birth without sedation of the woman and fetus. It is used for both vaginal and cesarean births. Epidural blocks are started and maintained by an anesthesiologist, physician specialized in administration of anesthesia, nurse anesthetist, registered nurse with advanced education and certification in anesthetic administration. The epidural space is outside the dura mater, between the dura and the spinal canal. It is loosely filled with fat, connective tissue, and epidural veins that are dilated during pregnancy, figure 13.9. An epidural block is performed by injecting a local anesthetic agent, often combined with an opioid, into the tiny epidural space. Substantial relief of pain from contractions and birth canal distension. The level of the epidural block can be extended upward to provide anesthesia for a cesarean birth or tubal ligation after birth. Analgesia, rather than full anesthesia that results in complete loss of movement and sensation, is preferred for labor. Lower concentration of the anesthetic agent and an epidural opioid provide adequate pain relief without complete motor block, loss of voluntary movement, for most women. Higher concentration of the anesthetic agent used for abdominal surgery result in greater loss of both motor and sensory functions. Technique. The exact time to begin an epidural block is individualized. It is started just before a scheduled cesarean birth. For labor, the best time to start the block is when the woman is in active labor to avoid slowing progress. Several ways are available to customize the epidural block for different pain management needs. If she is in early labor and needs pain relief, the woman may be given parenteral opioids until her labor is more active. Or she may be given a preservative-free epidural opioid via the epidural catheter, supplemented with a stronger epidural anesthetic agent when labor becomes more active. In this way, she obtains pain relief and relaxation in early labor, with less likelihood that labor progress will be slowed. The epidural space is entered at about the L3-L4 interspace, below the end of the spinal cord, and a catheter is passed through the needle into the epidural space, figure 13.10. The catheter allows continuous infusion or intermittent injection of medication to maintain pain relief during labor and vaginal or cesarean birth. The infusion of epidural medication also may be regulated by a patient-controlled epidural analgesia (PCEA) pump. Epidural blocks require a larger volume of anesthetic agent because it is outside the meninges. Before the full epidural dose is given, a small test dose of anesthetic is injected by the anesthesia provider to determine whether the epidural catheter has inadvertently punctured a blood vessel or the dura. If a large dose of anesthetic reaches the subarachnoid space instead of the epidural space, the woman experiences rapid, intense motor and sensory block, loss of sensation. Numbness of the tongue and lips, lightheadedness, dizziness, and tinnitus may occur with intravascular injection. Epinephrine in the test dose produces tachycardia if injected intravascularly, although the tachycardia can have other causes such as pain. Epidural opioids that may be used during labor include fentanyl, Sublamaze, sufentanil, Sufenta, ropivacaine, Nerapin, and morphine, Duramorph or Astromorph. All drugs injected into the epidural or subarachnoid spaces should be preservative-free. A single dose of a long-acting epidural analgesic, such as morphine, is often given after cesarean birth before removal of the epidural catheter to provide long-acting pain relief with a low dose of opiate. The mother may require no added analgesics for almost 24 hours, or oral ones may be sufficient. The mother's respiratory status should be monitored for an extended time after the long-acting epidural analgesic, up to 24 hours based on the duration of action for the specific drug. Dural Puncture. Because the tough dura and the fragile web-like arachnoid membranes lie close together, dural puncture also punctures the arachnoid. If the dura is unintentionally punctured with a needle used to introduce the epidural catheter, leakage of CSF can occur, which may result in a post-dural puncture, spinal headache. Dural puncture and headache also can occur without obvious CSF leakage. Contraindications and Precautions. Epidural block is not suitable for all laboring women, and some refuse the block. Contraindications include coagulation defects, uncorrected hypovolemia, an infection in the area of insertion or a severe systemic infection, allergy, or a fetal condition that demands immediate birth. Women who have had spinal surgery, such as for scoliosis, spinal curvature, are evaluated individually. Adverse effects of epidural block. Epidural block can have several adverse effects. Maternal hypotension. Sympathetic nerves are blocked along with pain nerves, which may result in vasodilation and hypotension. Maternal hypotension, with possible reduction in placental perfusion, is most likely to occur within the first 15 minutes of an epidural's initiation or injection of intermittent bolus doses to maintain pain relief. However, a significant percentage of women may have hypotension that occurs within 1 hour of initiation or repeat bolus doses. In addition, the fetus is more likely to have non-reassuring signs on an EFM strip, for example, a prolonged deceleration, if the mother has hypotension. Non-reassuring fetal signs may have other causes, however. See Chapter 14.